A 70-year-old male patient presents with a 6-month history of shortness of breath. He mentions that it is worse on exertion and his exercise tolerance is reduced compared to previously. He describes no associated wheeze or hemoptysis but does have a dry cough. He has a background of hypertension and takes amlodipine 5 mg once a day. He has never smoked or worked with asbestos in the past. On examination, he is comfortable at rest with oxygen saturations 95% on air. There is no evidence of lymphadenopathy, clubbing or cyanosis. He has fine crackles at both lung bases that do not alter on coughing. You suspect the patient may have idiopathic pulmonary fibrosis and organize some investigations. Which of the following investigation findings would support a diagnosis of idiopathic pulmonary fibrosis? Idiopathic pulmonary fibrosis, IPF, is a chronic, progressive fibrotic lung disease that primarily affects the lower lung zones. Given this patient's progressive dyspnea, dry cough, and fine basal crackles, IPF is a strong possibility. Investigations that would support an IPF diagnosis include high-resolution CT, HRCT, scan. This is the gold standard for diagnosing IPF. Findings typically show reticular opacities, fine network-like scarring, honeycombing, clusters of cystic spaces, traction bronchiectasis, subpleural and basal predominance. Pulmonary function tests, PFTS, these typically show a restrictive pattern. Reduced total lung capacity, TLC. Reduced forced vital capacity, FVC. Normal or increased FEV1-FVC ratio. Reduced diffusion capacity for carbon monoxide, DLCO. Serological tests, these help rule out other causes of fibrosis, such as connective tissue diseases. However, they are not diagnostic for IPF. Bronchoscopy or lung biopsy, in uncertain cases, a surgical lung biopsy may be performed to confirm usual interstitial pneumonia, UIP, pattern, which is characteristic of IPF. Oxygen desaturation on exertion. A 6-minute walk test may reveal oxygen desaturation, which is common in IPF.